I hope everybody's enjoying spring in November. It's which is basically what it is at the moment.
Yes, it is.
Hi, Dr. Zhang. How are you?
I'm good. How are you, Dr.
Good, thank you.
Michal, and everyone? Good.
Hi, everyone.
Hello, hello. Welcome, welcome.
Thank you.
You know, Alison, the sad thing is I've seen more of you because of this meeting than we normally do, although we're colleagues, you know.
I would have to agree. It's been nice though, but
No, I know, because I mean we have all our communication through the electronic medical record, so there's, you know,
I would have to agree. No, it's a nice way to get to see a lot of individuals I don't normally get to see.
right.
Although today I'm going to have to skip. I have a patient at 1, but I'm
Oh
glad I
no,
get
of
to be
course,
here
yeah.
for a bit.
Yeah, yeah. No, we'll and we want to you know, move along efficiently as well, so we won't take up unnecessary time. I mean, we're only 2 minutes into the meeting. For most meetings, I give like 4, maybe 5 minutes, if that's okay with everybody.
Sounds good.
I'm not sure if Elizabeth Conklin will be joining us. Here we go. Hello.
Good afternoon.
Good afternoon. Hello. So, Peter, did anybody say they would not be able to attend so that if they did, we needn't wait?
Oh, I'm checking on that right now, Lena.
I know Dr. Dawson said she couldn't make it today.
Yep. Thank you.
It seems that mostly everyone who replied yes to the Zoom invite has joined. We're just missing Dr. Moreno. So
Okay. Okay. All right. Well, I know he's a busy clinician, so maybe he'll be joining us in a few minutes. And we're almost at 5 past. Okay. So if it's okay with everybody, we can start or convene the meeting as the agenda item says. And perhaps we could just start off by looking at our agenda for today. I'm just going to share my screen. I have a few items which I think will help us get through this meeting. So hopefully what you can see currently is our agenda for today. Is that right? Actually, that's not today's. That's not today's. That's today's. That's not today's. Where's today's? Okay, it looks like I don't have today's agenda up. Peter, could you help us, please, and maybe just tell us what the... There we go. Maybe I can open it up from here. No, that's the October 9th. Looks like I don't have today's agenda open. Peter, could you perhaps help us, please? Would you have that open or nearby?
I can find it. Watch.
Okay.
If you want to get started, I can find it.
Um, Actually, I have it here.
Okay.
Thanks. Okay, so as we can see, so obviously convene the meeting, and then we were going to, go over the conclusions and recommendations from the previous meeting. And it might be helpful if I put those up on the screen. Do you currently see the Word document, or
Yes,
what?
we see that.
You see the Word document? Okay. So, so these were our conclusions and then some recommendations that followed on from here. And I was going back and looking at these, and I just want to make sure that we are actually, providing recommendations that are helpful. The first one also I think we need to revisit, which is the Medicare database be analyzed for assessment for prevalence of fatty liver disease. And Elizabeth had very kindly shared some data with us, which I will try and put on the screen. And I don't know how many, we had this available shortly before our meeting 2 weeks ago, but also I'll just make it re-available here. And I'm not sure how many of you actually had a chance to look at this. One reason I didn't go over it last time was because, we just received it sort of the day before. And we can go over as much of it as you wish. This is the first table. And sort of what I wanted to highlight really was the data on simply the number of inpatient discharges that were associated with NASH, and obviously the percentage that comes from that. And of course, the number is extremely low if we compare it to a very large number, which would be, say, heart disease, for example. And, based on the epidemiology of NASH, I think we're still hitting the issue of limitations of using an ICD-10 code to pull out the data. And also because it may just not be coded in such a way because it's a more indolent disease. Obviously, a heart attack or stroke are, not indolent diseases. It's very obvious when a patient has either one of those. And as far as diabetes goes, which is a third one, patients often come in with that diagnosis already. Whereas something like NASH, if it's not been identified previously, meaning when the patient comes into the hospital, the likelihood that that will be diagnosed in the setting of an acute medical admission is actually very low. So I think, the issues that were present in the published data are also sort of showing up here. I'm not sure what anybody else thinks.
Does the diagnosis also require pathology too for the NASH?
No, it doesn't require pathology, and pathology would be very, very rare that anybody would be biopsied.
Okay, thank you. Yeah.
Yeah, I think this might be also an issue of terminology because NASH is a subcategory of what previously was called NAFLD and now is MASLD. So there's MAFLD, there's NAFLD, there's NASH, there is fatty liver, so many potential terms that could be used. And so I think that may also be an issue that we're not capturing all the ICD codes or
Right. But they'll all get distilled down to an ICD code. So I
Sure.
think I agree that terminology is unfortunately uh, confusing, frankly. But the ICD codes, of course, would capture them. So one option would be to, suggest a broader grouping of ICD codes. But I think that still the issue is the underlying one, which is that there are large numbers of people with this indolent condition who are just not being identified,
Right.
and if they're not, then by identified, what I mean is that the condition is not ending up in the electronic medical record as a distinct diagnosis. There is information there. So, for example, if one was to do a word like search or AI scan of terms like steatosis or some ultrasound-based imaging, things would pop up. But that happens, but then it doesn't get turned into a formal diagnosis Or for example, the liver blood test like AST and ALT. I mean, those are abnormal in 5-6% of the population. And that could be picked up obviously by an electronic medical record search, but it doesn't get turned into a diagnosis. Because it could be due to several things. You could have elevated liver blood tests because of a statin, or because of alcohol, or because of NASH. So that's like actually what we're facing. So I think this was extremely helpful. I just don't, with the limitations of the ICD codes, I'm not sure how much further we can, go with this, if you see what I'm trying to say. I'll invite suggestions from anybody else on the call. I mean, we have to come up with obviously recommendations, and it's partly because of this, and partly because of item 4, which is methods of increasing public awareness of such diseases. Actually, item 5, which is implementation of statewide screening. I think what would be extremely helpful is to somehow encourage, and we can discuss how we would encourage, development of algorithms which can screen electronic medical records, right? I mean, item 5 actually says, let me see if I can. Okay, I'm not sure. Is my screen changing as I change? Is your view changing as I change my screen?
Yes, we can
Okay.
see the list.
Okay. So this is what I was referring to, and I don't mean to jump around, but it's directly relevant to this. One of our tasks is implementation of statewide screening program, and often people think of screening, naturally enough in terms of going out there and screening the population, right? I mean, checking blood pressures or hemoglobin A1C or what have you. But I think in this case, we can actually screen the electronic medical record system, because there is a lot of information in the electronic medical record system which is not being utilized. So what this would be, at a simple level, would be something like running a screen for what's called a FIB4, which is basically a score that comes from using, some simple parameters like ASDLT and age, or a more sophisticated electronic medical record screen, which might, pull in other factors. So my suggestions are twofold. One is that I think that the ICD codes simply won't capture the disease that we wish to capture. And secondly, to get around that, and also to speak to what I've highlighted as point number 5, is to actually recommend a statewide EMR screening program, which would, because I think it's relatively low-hanging fruit, and I think it will give quite a high yield, and clearly would not be as requiring as much resources as if we were actually to go out into the field and actually start screening people.
Well, I think that's a good idea. Would you see such recommendation as fulfilling the earlier questions about getting a sense of epidemiology and prevalence, or would you see that as implementation, or both?
No, I think it's both, right? I mean, so these are some of the earlier recommendations.
Right.
Incidence of disease
Right.
in
Prevalence.
Connecticut,
Yeah.
and then also identifying subgroups or groups which are most affected. So a screening program would, if successful, would achieve both of those.
Mhm.
I mean, the ultimate screening program would be if we were to recommend, say, a FibroScan test in everybody over, with a BMI greater than 27 every 3 years, right? I mean, that would be the ultimate screening program, because we would actually go there and collect new data from people. But that's clearly not going to happen, right? I mean, that's the resources required for that would be not astronomical, but significant. But to screen the electronic medical record system, I think is very doable. So again, I'm bringing up 2 points here. One is, that I think it'll be very difficult to get accurate data because the ICD code is right downstream from everything else that's happened to a patient. And obviously, if the concern is that things are not happening, then ICD codes are not going to be used. So I was going to suggest to not pursue the ICD codes anymore for now, because I just don't think it's going to give us the information we want. And then similarly, and associated with this, to recommend electronic medical record screening approaches. And we can firm those approaches up as much as you wish. I mean, they could be super simple, such as just screening for abnormal liver function test. I mean, there are many, many people sitting in primary care clinics with mildly elevated AST ALTs. And it could be as simple as just that, which would really be like one line of code, basically. Is the committee okay with those two related suggestions?
I think I do agree about the limitations of the ICD. I think definitely an EMR screening um, might have more utility, but I'm just wondering what modality or what parameters would be highest yield, because at the same time, AST and ALT also we know is they're very non-specific. There's so many things that could cause elevation. You get on antibiotics or you have, so I don't know what percentage of patients with elevated AST, ALT actually have fatty liver as the cause for that.
Right.
So I'm wondering if it will also be very like non-specific and catch a whole bunch of people that really don't have
No,
fatty
and
liver.
you're absolutely right. And I just gave that as the most simple example, but clearly it has all of the, defects. I think the discussion as to how one would set up which parameters we would use to screen the electronic medical record is quite a big discussion on itself, and I don't think that's a discussion we can uh, usefully have here.
Right.
I think our discussion here really is whether we believe the approach is helpful. And if we believe that, then that's fine. And then, down the line, it'll require a lot of detailed discussions to see exactly how we would, set that up. Would we, include BMI? Would we include waist circumference? Would we include triglyceride levels? I mean, these are all
Right.
things that would need to be discussed. And we would need to obviously have some EMR experts on the call as well to let us know what's actually feasible. So, okay. Well, keep this in mind, and certainly we can come back to it if you would like. And also in the meantime, if anybody, can identify additional things we could do with ICD-10 codes, I mean, we could certainly, revisit it. The other thing was that we had come up with recommendations, or actually not even a recommendation. These were just minutes from last time. And I just wanted to go over and make sure that we were taking the steps that we said we would take. Okay, so one of these, of course, we had discussed about recommendations related to nutrition. Okay, so what I have done is I've looked up a couple of resources, and I'll put them up here. So one is the American Heart, which I thought was quite good. And obviously, the topic of lifestyle intervention to help with metabolic syndrome related conditions, it's obviously been addressed massively by, many, many people. And I thought this was, quite a good one. And this actually is from an endocrinology society. So it's a slide set. I mean, it's quite a large slide set of 51, and it's quite simply written. But I would say probably still geared up more for the healthcare professional. And you can see, obviously, I won't go through all of the slides, but just to give you an idea. So this is the American Association of Clinical Endocrinology. So I was going to suggest two guidelines. One is this, and the second one I pulled up and I thought was quite good is the American Gastroenterological Association, which specifically, speaks to lifestyle modification using diet and exercise for NASH. The one that I showed you previously is one in general for metabolic syndrome and health. And this one is specifically for NASH, which I thought was obviously relevant. Clearly, they mostly say the same thing, not surprisingly, because they have to do with diet and exercise and such like. This one is a little bit more academic, as you can see from the way that it's laid out. But if the working group agrees, I will basically submit both of these and say that we as a working group are in agreement with these. And I mean, I'll share both of these with you, and certainly you can take the next 2 weeks to review them and see if there's anything in there that perhaps you don't think is sound. But otherwise, I think it's very reasonable to submit these two. And if you have another one, I mean, there are half a dozen national organizations that have come up with lifestyle guidelines. I'm happy to include another one as well. Would that be okay?
I agree.
Okay, hey Liz, how are you? And Alison, of course, this is right up your street as well, because obviously nutrition is a huge part of, well, it is what you do. But so again, I'll share these. I'll ask Peter if he can send these out to everybody, because we certainly don't need to go back and reinvent the wheel with this. Sorry, I'm just going back. So I just want to make sure that some of the things that we said we would do, and I've just highlighted them here. Yeah, and this is again huge overlap between lifestyle, between obesity and fatty liver, recommendations. Okay, and I do want to highlight at some point, I'll make a specific point of this, that the Hispanic population is at higher risk, because we do see this divergence. I mean, many groups in underserved areas are at high risk of obesity and metabolic syndrome, but the Hispanic population is particularly at risk of fatty liver disease. And then Dr. Richardson brought up this important issue of food insecurity, which obviously, is rolled up within lifestyle. And I pulled up this quite helpful. It is a newspaper article. So what I mean by that is it's not a peer-reviewed academic journal article, but it just has a very useful map, which lists the food deserts. I have to stop myself from calling them desserts, but they're food deserts, not food desserts. In Connecticut, and they are where you would expect them to be. And then there are obviously criteria that the USDA has for food deserts, which is also linked in this map. I won't go into it, but um, if we wanted, I'm happy to pause for a few minutes if anybody wants to speak in particular about this. Not surprisingly, they are predominantly in the inner city areas, in New Haven and Bridgeport, New London, parts of Hartford, Waterbury. I guess Stamford surprised me a little bit. But so I was going to actually sort of submit this as well. At least we can identify them. What we can do about them, I'm not sure. But the first step, of course, is just identifying the problem. And then further down, actually, the other thing that's useful is obviously, we're not the first people, we're not the first working group to, bring up this issue. And this article is from summer of 23, and it does speak about some attempts to try and alleviate this problem. And I don't know the details of these bills. So it says a food desert bill provision. I'm not sure if you can read that, so I'm reading it out. Formerly part of House Bill 6854, were incorporated into House Bill 6941. And this is from last year. I just haven't had a chance to, figure out what happened to these bills. But, we could obviously look into what happened to these bills and see if it's worthwhile resurrecting some of these if nothing happened to them.
I know we were talking about from the school system standpoint as far as availability for foods,
Yep.
but I know that's a big area as far as, and this is bills within themselves, but obviously what's being served and what's available from the student standpoint, for the meals themselves and the makeup of the nutritional components for
Absolutely, absolutely. And
School,
I was going to, thanks for bringing it up. I was going to get to that a little bit because it is obviously related to the geographic issues as well. And for that, I had reached out, and I forget the gentleman's name, but I haven't been able to be successful in having a conversation yet in the education department. And we can jump to that if you would like. Let me just see.
John Fresinelli was the
Yes,
contact.
thank you. Thank you. So I'd sent him 2 emails over the last couple of weeks, but I just haven't had a response yet. So anything else we would like to, maybe what I'll propose is, because I think we have to propose something, that I'll look into these bills and see what happened to them. I literally just don't know. I mean, but obviously, not surprisingly, this issue has been addressed in the past. So I will, if with Peter's help, just try and figure out where the momentum on this topic is at the state level. Okay, so there was that, and right, and here's reaching out to John Frassinelli, which hopefully I will be successful in doing before we meet next time.
Dr.
Okay.
Mahal, may I jump in for
Yes,
one
of course.
second? I'm happy to reach out to him and ask that the two of you are able to have a conversation. I will do that today.
Okay, thank you so much. Sorry, I'm not paying attention to the hands up. I'll do that more. But thank you so much. That'll be extremely helpful. And Dr. Richardson had said that had said that she has some contacts with the state chapter of the American College of Physicians. So if you could just circle back to us on who that is. I mean, obviously you can reach out or whatever you would like.
Will do.
Okay, thank you so much. So
Welcome.
I just wanted to go over, because we write these minutes, but some of these have to do things that sometimes don't get done. So I didn't want to miss that. And then, we can move on to other policies. So, according to the timetable, this is our topic for today, but in fact, we'd spilled over into it last week as well. But we can briefly touch on these in case there were items that people had additional ideas. So, strategies for preventing disease in high-risk populations and how they can be implemented statewide. With statements like that, I guess I shouldn't hesitate because we can just come up with aspirational stuff, right? We can just do that. So the food island topic, scarcity regions is an obvious one. So well, following up on that will help with this. The school meal situation for which I'm currently completely ignorant about, but maybe once we hear back, that can be helpful. Any other strategies? Just identifying from the EMR how many people and which areas the disease is most prevalent in will obviously be helpful as a starting step. Okay. 6 is related to 3, which is to improve care and outcomes. For that, I think the biggest thing would really be access to healthcare professionals. So again, I think the information is there in the electronic medical records. We just need to encourage our primary care physicians to, act upon it. And then for number 9, which is the manner in which social determinants, that's almost sort of an academic question. One could just write or identify the main social determinants. But the second part, which is interventions needed to address these determinants. Again, I think we're ending up sort of in aspirational categories, but that's fine. I think we've been told that's fine. So we can suggest whatever we think will be helpful.
I think at the last meeting we had discussed that there were 5 main social determinants of health, and we would pick each of those and, find a subset of something
Okay.
in each of those determinants to focus on.
Right. So, yes, that's what we had said. So, one of us, perhaps I can just go through, identify two, and then share them with everybody and see if that's fine, or if you would, pick a
Sure,
different
I can.
two. Or
Yeah,
would you like to do that, Boo Boo? Okay.
sure. Yes, I can do that.
Okay, that'll be great. Thank you. Okay. Um, so we're sort of moving through these fairly quickly because according to our schedule, B was what we were supposed to be addressing at this meeting, and this is the next week's meeting or next meeting. So and the reason I'm saying that is I just want to make sure we're actually, making recommendations that are helpful. I almost feel like we're going through them a little bit too quickly, just if you see what I mean, because um,
I'm actually okay with the speed. I think that they all interconnect. And so even if it were that we've run through and then came back, that would be okay because we also need time to,
digest
write,
some of it. Sure.
digest and write and go back and forth with that.
Sure. So maybe what we can actually do is just review. One of these has the timetable on it. Okay, here we go. So here's the timetable, right? So, we are obviously here. So we have 3 more meetings. Okay. And obviously by the meeting of the 18th, what I would like to do is to have, a draft document with our recommendations, which hopefully everybody can agree upon. So we have, 2 more meetings to, I guess, go through these two. So that's fine. I think if we can, if we can just nail the items that are in turquoise here, then I think we're fine. And maybe go over. I guess what I just, before moving from, B onto C, I just want to make sure that we're not missing an opportunity to make recommendations, because the opening they've given us is huge, right? I mean, they're basically giving us, these massive openings of saying, tell us strategies to prevent this kind of high risk population. I mean, that's just like a tent. Um, and we haven't come up with an awful lot at the moment. So
I was
and
just, I was just taking a look at the DSS
Mhm.
Medicaid data that you showed earlier, and I was looking at, you had just shared the Connecticut Mirror article about food deserts. And I was just comparing that little document about where the higher numbers are in the Medicaid and where the food deserts are, if there's like a connection. So I was just, I know, I
this
thinking of your
this map.
approaches of like,
Yeah, I mean, I think part of the trouble that I find is that a lot of it is just so obvious. Do you know
mm,
what I mean? I mean, it's difficult to make a statement like the sky is blue, right? I mean, it's like, why are you telling me the sky is blue, right?
yeah.
Because I mean, it's kind of obvious where the issues with nutrition are. I mean, they are all in the inner city areas. So
And
we can make statements like that, but I guess I hesitate telling people things that they already know.
yeah, I was just looking at the Medicaid that said in terms of those people with NASH from the DSS Medicaid data that, looking at the rates, I was just curious to see if the food deserts match the high numbers of diagnosis from Medicaid population in those counties. So it might be obvious. I was just trying to see if it matched up. If there's a high
Oh
number
yeah,
of NASH
is
diagnosis with food deserts to its, which kind of supports the story that you're.
right. I mean, the trouble with diagnosis, of course, is access to healthcare.
Mhm.
That's the big issue. This is a indolent condition. I mean, obviously things that are in your face, like a stroke or a heart attack, don't get missed. But these types of things do. But is there something you'd like to share on your screen regarding this so we can kind of,
Sure, I can.
okay, I'll stop
You
sharing.
shared the screen earlier. It was the Medicaid data that I shared from our.
Oh, do I have the
You
information as
have it.
well?
Sorry, you have it. It was the first document that you opened up, and then we
Oh,
went.
okay. Sorry.
Not that one. That one's the hospitalization IC
Oh,
code.
is it a Word document?
Yes.
Okay. Uh, there's a file with your name on it.
It says DSS
Yeah,
Medicaid.
it's actually it's an Excel
Yeah.
document. This
So
one.
down at the bottom, I was just looking to see, I was curious because I was just curious, does the
Oh,
food
right,
district
right, right,
match the
right.
number of
Sure.
diagnoses from Medicaid
Well,
population? So this isn't all encompassing, but this is a
I
snapshot.
understand. But maybe if I can be a little bit coordinated. There you go. Can you see both at the same time?
Yeah, yes, yes.
I think
Oh,
that's
there we go.
pretty amazing. Okay.
So you're
So New Haven, New London, Hartford. Can anybody spot others?
the Fairfield would include Stanford. Fairfield County includes Stanford.
Okay.
I was just curious, it kind of matches in some
Yeah,
way.
no, for sure. So, I mean, it may be that the denominator is low, um, meaning that we're not picking up all the people we should. But even if the pickup rate is low, it might still vary based on what the prevalence is.
And it might correlate that bad options or less than ideal food options for people in some of those food deserts does not support healthy eating, which, as you're indicating, does not support NASH. NASH. Healthy
Right, right.
diet is important to preventing NASH. So I guess they're
No, exactly. So I mean, just sort of, for example, just pushing this when, your high risk population is sitting in a food desert is obviously s- kind of pointless, right? So I think that's what you're suggesting, right?
never pointless, but it's a
No,
challenge.
not pointless, but obviously, is has issues, right? So
Yes,
I should
yes.
be
But I
careful
was
what
just
I
trying to
say.
make that. I want to make sure what I was thinking matched to some of the numbers. So thanks for going through that little exercise.
No, no, it's absolutely true. I mean, so, um, this issue is a very much a real world issue. And obviously, although these are areas that, have been classified as food deserts, I'm sure if we looked at access to medical care, it would probably also be quite low, although that's not what this map specifically shows. Um, so again, I just want to pause a little bit because these are we are given huge openings to make recommendations. So I guess and again, my expertise is not public health. I'm more of a experimental biologist and NASH clinician. So I shouldn't have. I, I'm certainly won't have the best suggestions amongst all of you. But those of you with a more of a public health expertise, please, you know be creative in how we can handle it because we can literally see the problem in front of our face on this map. So and you can get back to the whole working group at some later time point as well. So okay. Um so perhaps with that we should move on a little bit. That was the last. Sorry, keep okay here. So yeah, so the turquoise is really the meat and potatoes of what we should be addressing, and hopefully we can always come back. But the ideal would be that after the end of today, we have as at least as a group addressed this. You can always add things afterwards. Okay. So moving on to C, methods for increasing public awareness of such diseases, but not limited to campaigns. Um, you know, since many of these topics are interrelated, we do end up going back to the same things. Obviously, reaching out to the school districts and healthcare programs within the school districts is an obvious one. reaching out to the state professional organizations like American College of Physicians to see how much they can incorporate in perhaps their annual meeting, would be another one. I can't imagine, it'll go all the way to the extreme of actively advertising health concerns, billboards or radio ads and such like.
This actually is what I was thinking. I was thinking
Oh,
what,
really?
yeah, because, you see things about smoking or alcohol on billboards, don't drink and drive. So, is that a possibility to really, put more of a public health issue? This are your risk factors. Have you asked your provider if I have fatty liver?
Yeah,
You know,
that's fine. I mean, again, I'm hesitating because I don't have a public health background. So,
right.
you know, um, but no, absolutely. I mean, I think if the committee feels, if the working group feels that that's something that's reasonable, then I guess our main thing we have to consider is, would it be effective, right? I mean, that's basically our job at this point. And if we think it'll be effective, even if it seems aspirational, we can propose it. So okay, so we'll do that. We'll propose, some concrete things, such as radio ads, such as perhaps billboards. Obviously, again, focused in those areas where we expect that there is a significant population at risk.
I think you should include, as we were advised last meeting, to put your wish list in there and not worry about the costs associated, but one thing to add, you had talked about billboards. What about, that's a macro level education. What about a micro level, like uh, information for primary care offices about the awareness, letting people even know about NASH? Like, I think people are aware of healthy lifestyle and being over, obesity
Hmm.
and exercise, heart disease, but I don't think it's commonly known. And people don't know what NASH stands for. They're not sure what fatty liver. I think fatty liver can be often perceived as something that's associated with alcohol. So I
Hmm.
think like just general basic
Yeah, no,
education
thank you.
about.
Yeah, thank you. And we could, I mean, I've always, when I've thought of that, I've thought of three groups. One is the primary care, our primary care colleagues. One would be for teaching in schools,
Mhm.
and then the third would be geared towards parents. You know, co-professionals, parents, and the actual students. Those are the three. So we could propose to, generate some materials. Perhaps it could be a simple trifold or a slide set, etc. I'm sure I think healthcare lessons are given to students in
10th grade.
on various topics. So even if we prepare a slide set of say 10 slides, which at least a teacher would have available, if they wanted to cover the topic of fatty liver disease.
Yeah, that would be extremely helpful. You know.
Just one other thing to kind of piggyback on to in terms of like a campaign, potentially utilizing social media as a resource, a social media campaign. I think when it comes to liver disease, in my mind, a similar model put forward by the World Health Organization when they wanted to eradicate hepatitis C was there was a campaign called No Hep, and so something similar along those lines, utilizing social media platforms as well, could potentially be helpful.
Right, and absolutely. I mean, once we obviously, and again, trifold obviously sounds antique these days, but I mean, there's so many. Again, I'm not a social media expert, but that requires at this point a social media professional, right? Because there's so many different apps and such like. There is something that's called a Global Fatty Liver Disease Day. We could also basically suggest that the state does something and we can discuss what that something might be on that day. What we do over at Yale New Haven Hospital is that week, on the screensavers in the hospital, we just put information for fatty liver disease. So at least for that week, in all the healthcare providers, before they're logging on, it'll just pop up. But we could certainly recommend that the state take some step to recognize Fatty Liver Disease Day. So I'm not sure at what levels the state recognizes various days and events. I don't know if anybody can fill us in on that. Obviously, there are certain national holidays and state holidays, but short of that, are there any other sort of
I can
yeah,
speak to
yeah,
that.
please.
I was in the DPH Office of Communications for 6 years, which is one of the reasons Barbara Cass asked me to join this group. So in terms of, and I've worked on many campaigns. So yes, DPH does have a social media, and we do recognize certain health observances depending on what they are. But in terms of the concept of a campaign, there's various levels of campaigns, and that usually is conducted through a media provider. Like DPH doesn't create videos. We usually work with a Connecticut professional media group. But in terms of social media, you can geo-target. You could say, okay, we know that the Hispanic population in these 5 counties where there's food deserts are most at risk, and you can do ads through digital media. So they can actually target people in those communities, and they can make things in Spanish, English, depending. So there is a lot of ways to be efficient with health education and information, as opposed to a billboard, which reaches is kind of everywhere, but they call it geo-targeting or based on geographics.
Right. No, of course. Yeah, I mean,
So
I'm
those
just
things cost money, but they are possible, and it is, if would be something to consider for your recommendations to make sure,
no, for sure. That's super helpful, actually. I mean, and maybe, I can get your advice in a little bit more detail outside of the
Sure.
working group as well as to how that might be done. But that sounds extremely helpful. I also think that, linking it to a national day and linking it to another organization can be helpful so that it doesn't seem like we're just out on a limb by ourselves. So if there is which there is a global or annual fatty liver disease day, then on that day or that week, we can really have more of a burst because, I mean, nobody wants to hear about fatty liver disease every day of the week, right? But maybe 1 week a year.
I don't know if how it works in the medical professional world, but in terms of conferences or things like that too, is it something to consider raising awareness within the networks of physicians? Do you have like an annual conference or
Yeah,
see
there are
ways
state-based, exactly.
to-
Yeah, there are state-based conferences for physicians. I mean, obviously they're not huge in size, but yes, absolutely. That's a good idea as well. But I think, reaching out to patients. And what's interesting, and I'll just sort of say anecdotally, is that, when individual patients are told that there's something wrong with their liver, most seem to take it quite seriously. There's this general realization that it's sort of important. So, okay. No, great. And, obviously we'll have minutes from this, and from that I'll write out with specific recommendations. Okay, and we had, again, because all of these things are interconnected, we're coming back to this implementation of a statewide screening program. And my suggestion would be to have a statewide EMR screening program. So we've discussed this, so unless somebody has something else to say, we can move on from here. Obviously, what we are omitting by saying that is a real world screening program where we actually go out into high risk areas and actively screen, however that might be, ultrasound or blood test or whatever.
Isabel, is that something that in your experience at DPH may have happened before for any disease entity on a statewide level?
There's many programs within DPH, so I can't speak to all of
Right.
them, but I can certainly say usually there's an awareness of some general data that said this is where the high risk populations are for this specific disease, or so that it's very difficult to do screening across the state. It tends
Sure.
to be starts with a high risk group first or area and then builds, but
Yes, yeah, and also this also relevant to some of our previous conversation on establishing a new cohort in the general population. So if we can identify a high risk population, along with maybe like the public campaign thing that may help us to identify or establish or lay the groundwork for
Right.
some future potential population-based high-risk
So
prevention or intervention.
yeah, I just want to be clear. So we're now speaking about active screening, right? Actually going into the community and we can decide what that is. But okay, no, that's fine, and we can do that. Um, do we have a similar statewide map of in say where the Hispanic populations are particularly? Is that sort of information that's readily available? Maybe. I guess nobody on this call knows, but because we know based on genetics that's a high risk group, so it would be very rational to, and some of it may or may not overlap with the inner city areas as well. We can't make assumptions that it necessarily would. It may or may not, but um, okay, I will try and see if such information is available because that would certainly make things easier for us. Okay. And then the final point in this group C is the creation of a patient advocacy and support network to assist persons living with such disease. And for this, I would actually lean on the American Liver Foundation. I mean, we already have a national network which has, reach into each individual state, of course. So I don't think we need to reinvent this, but maybe what we could do is highlight the work that the American Liver Foundation does, highlight their meetings, how patients can contact them. They'll have a helpline and such like. Does that sound reasonable?
I totally agree with them. I'm actually on the National Advisory Board for the American Liver Foundation, and they are, I mean, NASH is one of their main areas of focus. So I think that it will be really good to link patients up with the American Liver Foundation and other similar national groups or state groups. One thing that the American Liver Foundation is doing also is setting up a patient registry so
Mhm.
that patients can go in and enter information on their liver disease and be able to come back and keep a longitudinal data.
Updated.
Right,
No, that's
right.
tremendous. And obviously, you and I are in the hepatology field, so it seems very obvious to us. But for somebody who's not in the field, there is the American Association for Liver Disease, there is the American Gastroenterological Association, there's the American Liver Foundation. It's not immediate, and the first two that I mentioned are really not particularly patient focused.
Mhm.
So it's not at all obvious if somebody, if a patient just Googles, American and liver or something like that, it's not immediately obvious which would help them the most. So I think this could be a relatively easy impact thing that we could do. I mean, how we should get the information out, I don't know. Simply having listed in our minutes that the American Liver Foundation is a good resource, I don't think is going to get much done. You know, so but maybe that could be part of the outreach, right? I mean, if we are successful in having an annual outreach, say the week of fatty liver disease, in that we could make a point of listing the American Liver Foundation.
Right. And also maybe awareness to primary care physicians or medical providers. And I think the American Foundation, Liver Foundation also has one of their goals to do outreach. So they may also have, suggestions as to how they can actually get word about their services to
Yeah, right. No, that's an excellent point. And this, I mean, this can be a two-way street because I mean, what I've highlighted as point 8, patient advocacy support networks. Frankly, this is probably one of American Liver Foundation's goals as well.
Yes, it is.
So,
As it relates to a campaign, they may have some resources already created. So if that was something that you did or you had funds or whatever,
mhm,
that, they've obviously had some time investing in how to reach people and done some
right.
usually focus groups on the effectiveness of a campaign versus trying to come up from something from scratch. So
So Boo Boo, since you're on their national committee, could we leave that to you to just
Sure.
investigate a little bit more and see if they just let them know what's happening, and then obviously what's happening, and see if they want to contribute either with information or something else. Because I mean, as we're speaking, sort of what's developed, the image I'm developing is that 1 week a year, synchronous obviously with the fatty liver disease day, we do something in Connecticut,
Mhm.
some sort of a stuff, right?
Awareness,
I'll leave it at stuff at the moment,
right?
whether whether it's through apps or whatever. Okay, that sounds good. Okay, well, we're approaching the hour, and I feel a bit better about going through these topics 'cause I think we have discussed them a little bit. We should probably go back to our minutes to see. Seem to have all the minutes except the ones that
I have one comment. Is
Yep.
Jorge?
Yes, hi.
Hi,
Please.
sorry, I know I've been in and out of some of the meetings. So
No, that's fine.
and I don't know if you guys spoke about creating like a website, maybe linked to DPH or something to create like education or additional resources for fatty liver disease on like some sort of like state website. Did you guys discuss that already?
No, but so we definitely discuss resources and everything from, old time stuff like trifolds and posters and billboards to, electronic messaging. So we discussed that. We hadn't specifically discussed a website. I
So
don't,
I'm just looking at the website now. There's certain information that like respiratory like is very like important right now, and like mpox and different things. And I think the commissioner of health, Manisha, does some videos. So I don't know if creating like informational video that could be on the website could be something to like as an ask or as a
no, for
something
sure.
to
No, for sure. And, the fact is that there are actually, not surprisingly, quite a few such videos around, but, they're dispersed in all sorts of places. But having them on a state website, or creating a new one. I mean, a video, if it's one person speaking, is trivial to make these days.
right.
Okay. No, absolutely. So, I guess as you're saying that, what I'm wondering is, would this essentially be a permanent website, or is this, part of the state public health website, which is basically highlighting certain things, obviously, flu in the winter and allergies in the summer and things like that?
Well, I don't know. I guess we can ask for a website and then we can tag it to the main DPH website, or I don't know
Okay.
if someone on the
Okay.
call has an experience with that,
Right.
but
Yeah, it was sort of a rhetorical question as well that I was thinking aloud. But no, that's fine. I think that can definitely go in terms of obviously outreach. Absolutely, we should have that as a recommendation.
On that website, I think we can also have links to other resources so that someone can come there, sort of as a home to they can go from there potentially to American Liver Foundation or to other resources.
Right. Right. No, for sure. For sure. I mean, we could get even more creative. I don't know if any of these influencer type people, I mean, one can reach out to these folks, right? Because frankly, many of the people that we want to reach out to, say teenagers and, people in their early 20s, I mean, how many of them are going to go onto a state website to look for
Right.
health information? I mean, that's not to say we shouldn't do it, but
well, I was thinking in combination with like your liver day or your day of or your
right,
liver week, it could be like here's our website, Liver
right,
Connecticut or whatever we
right.
call it, right? Or Liver DPH or whatever it is.
Yeah.
So it's I think it would be like a piece of the puzzle
Exactly.
for
No, it's
for
it's
for the week.
another net. No, absolutely. It's absolutely no harm in it will be helpful. I mean, and the other, I mean, just because of the wording you use, we can ask me, should it really be a focus once a week on liver health rather than fatty liver? And then we could bring in many more people. I mean, there's obviously more to liver health. I mean, fatty liver disease is the most common disease, but obviously alcohol is the other big one out there. I mean, there's still some issues with viral hepatitis, etc. And we can think about that
Yeah,
because
I mean, you're
I
right. I
think I
think
like that.
Yeah, I
yeah,
think right now, even for at the state level, it's more comprehensive because I was trying to find out whether there's data on any public websites in the state in regards to fatty liver disease. But no, it kind of lumped everything together, patients with chronic liver disease and patients with cirrhosis. So I think that makes sense to sort of put it together all under liver, and then we can subcategorize.
So when you say lumped together, you mean there is a state website that has this?
Yeah. There's
Oh, okay.
I think it's a national website, and then they break it down for the different states, and they don't differentiate the etiology of the liver disease.
I see.
Oh,
Well, I
it's
mean,
liver.
I was thinking more in
Right.
terms of if we're going to have, annually a once a week or a few day reach out, whether it could be just liver health.
Hmm.
And I
Got
mean,
it.
I'm just throwing it out there as opposed to
Yeah.
fatty liver.
Well,
Yeah,
I guess the question is, what's the asks from the state? Is it ask from the state to do it on fatty liver, or is it about liver health?
No, I
Because
mean,
then we're broadening the scope a little bit.
for sure, no, for sure. I mean, our mandate is fatty liver for sure, right? I mean, our mandate isn't alcohol or hepatitis B or hepatitis C, but if it's going to be helpful, I mean, we just, then we can consider that. I'm just throwing it out there, basically. I mean, by putting liver health, obviously it'll capture, since this is, the elephant in the room, it'll capture that. Something to think about.
In terms of the question about DPH web pages, DPH does create web pages for content, but typically it's associated with a program that has funding. So again, this would be resources would need to be assigned because
Okay.
once you create a page, you want someone who's there maintaining it, adding content, taking
Right.
down content.
Right. Of course. Of course.
And then in terms of social media, if you want to drive awareness, would that be something you're expecting DPH to do? Again, that would need to be, again, with resources because
Right. And we briefly touched on this before, is that when we make all these recommendations, I had intentionally not identified which state, channel would be doing this. I mean, should we? I mean, we're making recommendations, just leaving them open as partly because I don't know which would be the ideal state body to move
Yeah.
forward with this.
Yeah, we don't currently have a program that addresses liver health issues of various kinds, but I can't help but think about like some of the other chronic disease things that we're doing at DPH. And when you talk about getting people's attention for awareness, fatty liver is going to maybe not draw people, but saying liver health, it's not a bad thought to use it
Well,
as a way to
that's what I
capture
mean.
people's awareness, and then you
No,
get into the other. But I'm
well,
trying
no,
to,
that's exactly why, my ears sort of perked up because, it's easier to ignore fatty liver disease than it is to ignore liver health, to put it simply, right? I mean, you can't ignore liver health because I mean, everybody knows without your liver, you'll die. So,
right. So I oversee a program that is addressing Alzheimer's disease, and we start with the concept of brain health because reaching right into dementia is scary. But if you start talking about brain health and health
right,
promotion,
right.
it's at least a starting point to the conversation of bigger illnesses and diseases. So
Okay. Okay. No, I mean, I very
just a
much like it. I
thought.
mean, yeah, I mean, I think my ears perked up when that was mentioned. So I mean, let's certainly think about it. Obviously, we have a few weeks before we finalize anything, but I think that has a lot of potential because the other advantage of approaching it as liver health is that, there are other liver diseases, right? I mean, of course, and they may wish to have a footing at the state level as well. And there can be a certain level of exhaustion if then, at some point, you've got a different liver disease group comes along and says, oh, by the way, we would like our webpage, and we would like our week and such like. And clearly, there are 20 liver diseases. We can't have 20 different liver days. So, okay. Okay, great. So we hit the hour. So just going through, hopefully you can see the agenda. I finally have the right one. So we've gone through the bulk of it. Preliminary conclusions, recommendations. So I will draft these and circulate them at least hopefully a week before the next meeting. And as far as the date of the next meeting, we had agreed on the dates before, and that would be November 20th.
Is that the day before Thanksgiving, correct? No, it's
I think
sorry, the week
Thanksgiving is
before.
That's the week
the next
before, I
before.
think, week
Yeah.
before. So, right. So hopefully that's still fine with everybody. It's the week before. Yep. Okay. Anything else? Otherwise, we can adjourn.
I think that's
Okay,
it.
wonderful.
Thank you, everyone.
Nice to see everybody again. Take care. Bye-bye.
Have a good day.
Bye.
Thank you.